Thank you, and good afternoon, everyone. My name's Robin Young. I'm a medical oncologist at Western Park Hospital here in Sheffield. What we're going to do today is to talk a little bit about GIST from the point of view of the MDT. Patients, when they're referred into our service, are discussed at the Sheffield Sarcoma MDT. So I'm going to talk a little bit about how that service is organised. I'm then going to talk a little bit about how we manage patients with GIST, and in particular talk about a couple of clinical trials which are going to be coming to Sheffield hopefully fairly soon. And then after that, we've got Christine Ingram, who is a consultant radiologist, and she's going to talk about the radiology and show some pictures of GIST and the sorts of things that we're looking at on scans. Then we've got Marley Fernando, who's a consultant histopathologist, so she spends the whole of her life looking under a microscope at pink and purple blobs, and she's going to share some of those pink and purple blobs with you on the screen. And then after that, Maxine's going to finish off. Maxine's one of our cancer nurse specialists, who many of you already know, and she's going to talk about the support group and sort of the input that she provides to our service. Okay, so I'm going to talk about the management of GISTs. I'm going to just provide a very brief introduction to GISTs. Obviously, you all know what GISTs are. Talk about the sarcoma service that we have here in Sheffield, and then talk a little bit about clinical research. And what we thought we'd do is that we would give our presentations, and then at the end, you can ask questions, okay? So, as you know, GISTs are the most common mesenchymal tumour of the GI tract, so the most common sarcoma of the gastrointestinal stromal tumour of the gastrointestinal tract, and they are thought to be derived from interstitial cells of Cajole. And these are rare tumours. The incidence is roughly about 15 per million of population. So that means that for every million people, there are 15 cases of GIST. So the way that we diagnose GISTs are based on radiology and histopathology, and that's why we've got those consultants talking next. So radiology involves CT scans, MRI scans, PET scans predominantly, and then the histopathology is looking at biopsy material under a microscope. So for those of you who don't know where you are, you're in Sheffield. So our service covers South Yorkshire. It extends up to include patients from Barnsley, from Rotherham, from Doncaster. We also actually do go south as well to Chesterfield and a little bit further west. From the point of view of managing sarcomas, we also cover some of the patients on the South Bank, sort of going into Lincolnshire. So overall, the population that we provide a service for is about 1.8 to 2 million patients, that sort of order, okay. So within the MDT, what happens during the MDT is that we discuss patients' cases. We have a list each week that's about 40, 50 patients that we discuss, and we review information, so information about scans, from biopsies, to provide consensus and recommendations in terms of patient management. So from the point of view of managing GIST, the key members on the MDT are our surgeons. Unfortunately, they're in theatre this afternoon and we weren't able to tempt them away. We have Dr. Kotnis and Dr. Musson, who are our musculoskeletal radiologists, but Christine here provides a lot of the oncology input in terms of measuring response to the treatments that I give. There's Marley Fernando and David Hughes, who are our pathologists, myself as the oncologist, and then Maxine as one of the cancer nurse specialists. And then there's Helen Franklin, who's our MDT coordinator, who sort of pulls everything together, writes the reports and distributes those. And important members for the MDT, sort of extending further afield, as Mr. Patel and Mr. Skinner, who are surgeons who don't regularly sit within our MDT, but are our sort of go-to contact for GIST patients for surgery. So as a sort of rough idea, in 2014, across a weekly MDT, we discussed almost 500 cases. And of those, 99 were sarcoma, and about 25 were GIST. So, as I said before, we cover a population 1.8 to 2 million, incidence about 15 per million. So it's about that sort of order. We also see aggressive fibromatosis, another sort of rare condition, and a lot of benign lumps and bumps that aren't cancer. So the total that were classified as sarcomas that we discussed were 131 cases in 2014. And the numbers sort of gradually go up year by year. So this is just a rough diagram of how we organise our services across the Sheffield area. So no patient goes to see their GP and say, I've got GIST. And if you did, probably most GPs wouldn't know what you were talking about. So what happens is that patients get referred by their GP to somebody for investigation, or they may initially go to A&E and from there get referred on to somebody. And so there are sort of local services that will initially do a lot of the workup in terms of scans, perhaps even a biopsy, that raises the diagnosis or possible diagnosis of GIST. And then across the site, so there is an MDT for cancers of the upper GI tract, so of the stomach and the duodenum. And then there is a separate MDT that looks at cancers from the tail end, the colorectal MDT. If from the investigations they've done, they think that they've got a lump, they may or may not know that that is a GIST, but that it is readily operable, then they will do the surgery and then refer the case into our MDT. If there are queries, not sure what this is this a GIST, do we need to be looking at a biopsy first, the way forward, then they'll get referred into the MDT first, and then we sort of advise back to them. If the case is clearly not operable as it is initially presented, then it comes to us to decide how to take things further forward. And so we then end up having a discussion about what further tests are needed, who is going to do those tests, and how we take patient management forward. So one of the key things that we look at in the MDT is we often are referred in cases where there is a patient who has been diagnosed with a tumour and they've had surgery to have that removed, and that has shown to be a GIST. And so the question is, what do we do next for that patient? This is a table, rather complicated looking table, that we use to try to quantify the risk for that cancer coming back to help them decide whether we should be offering to these patients imatinib, Gleevec, as an adjuvant treatment. One of the key things we look at is where that GIST arose from, because that's an important predictor as to whether the cancer might come back. We look at the size of the tumour. Bigger tumours are more likely to recur, and then how active that cancer is, and cancers that are more active, that are faster growing, again are more likely to recur. So we put those things into an algorithm, and patients that we then calculate as having a high risk of recurrence, we would then advise they should have imatinib, and patients who get referred to me to have that discussion. So one of the key things, as you will all be aware of, is that many, not all, but 85% or so of GISTs are driven by mutations within the tumour cells. So these are switches, switched on within two particular proteins, something called the KIT and the PDGFRA receptor. And it's these switches that are telling the cancer cells to grow and to divide. And the importance of identifying these is because these switches is what imatinib works on to switch off. So particularly in patients who have got a very big tumour, where the surgeons say, it's too big, we can't operate at the moment, what we want to offer is imatinib to try to shrink the tumour down to see if we can then go on to do surgery. So if we're going to offer imatinib in that situation, we need to know that those switches are there for the drug to work on. Similarly, if a patient has had the cancer removed and we know that there is a high risk that the cancer could come back, and we want to offer imatinib to try to reduce the chance of that happening, then again we need to know that those switches are there so that the drug has something to work on. Otherwise we can end up giving patients treatment that isn't going to work but might cause side effects. Mutation analysis is an important thing for us to think about. We do it on all our patients where we are thinking about offering neoadjuvant or adjuvant treatment, and also in patients where we're thinking about it, where we're looking at as palliative treatment in more advanced disease. We don't do the mutation analysis in-house. It goes down to the regional genetics laboratory down in Birmingham, and they do the assays for us. These are not quick tests. It's not like sending a blood test to a lab to check your full blood count. This takes 2 or 3 weeks really for us to get the results back. So it can sometimes feel like a little bit of a hold-up, waiting for that result to come back, but it's very important in terms of then determining what we do to help the patient going forward. For patients where the cancer has spread or the cancer has come back, there are 3 key drugs which some of you will know. There's imatinib, which is the standard first-line drug, then sunitinib and regorafenib. At the moment, regorafenib is something that is offered through what's called the Cancer Drug Fund, and I understand is due to be reviewed by NICE, the National Institute for Clinical Excellence, who basically tell us as doctors what drugs we're allowed to offer to our patients. Fingers crossed that will still remain as something available for us to be able to use. And this cartoon here basically shows a little bit of what I was trying to say earlier about how these drugs work. So you have expressed on these tumour cells these receptors, these proteins, and underneath there are switches. Within the cell there are switches which are switched on, and they're sending signals into the cell telling it to grow and to divide. And basically the way imatinib works is to block those switches. So those signals then are no longer sent into the cell, and so it switches it off. So we have discussions at our MDT about whether we should be thinking about preoperative imatinib, whether we should be thinking about postoperative imatinib. There are times, unfortunately, where we give imatinib and it stops working, and so we then have to think about what we do next. And typically, for many patients, we are then offering second-line drug therapy, the drug called sunitinib. But we also frequently bring these sorts of cases back to MDT to see, are there other things that we could be considering? And so one of the things, for example, is there a role for further surgery? So sometimes what we see is if there are a number of different tumours, that sometimes it's only one of them that are misbehaving. So there can be an argument for saying, well, do we just do something to target that particular area? And sometimes that can be done with surgery. Sometimes that can be done with something called radiofrequency ablation, which is basically using radio waves to heat up the tumour and to try to kill it that way. And something that we've more recently been looking at is trying to use radiotherapy. Now, radiotherapy is something that normally we don't use for GIST. And the problem with, so radiotherapy is a good way to try to target a localized cancer. But the problem with radiotherapy is that you then expose normal tissue to radiotherapy, and within the tummy there's a lot of bowel. And if you expose the bowel to radiotherapy, it's a very delicate organ and it falls to pieces. So by and large, for most cases, we don't think about radiotherapy. But there's a technique called stereotactic ablative body radiotherapy, or SABR for short, which is a way of trying to give really quite high doses of radiotherapy to a very small area, and is actually something that we are now starting to question, is that something we could perhaps offer to select cases for GIST patients. So this is the radiotherapy machine where SABR is given. Initially, actually, so we've been doing SABR for lung metastasis, so cancer that's spread to the lung. Now, this is not something that's normally applicable for GISTs, which very rarely spread to the lung, but is something that we are offering for other sorts of cancers. But within Sheffield, we're then starting to expand that service to see whether it's something that we can use to treat cancer that's within lymph nodes, within the liver, within pelvic lesions. And obviously that is something that could be suitable for GIST. So it does require that there are relatively few tumours and that they are relatively small, so not something that necessarily is applicable for everybody, but it's another option. It's another thing that we can be thinking about doing, and that's good. So I'm just going to talk a little bit about some clinical studies. So one study which will be opening soon in Sheffield, and a couple of other studies that we hope will be coming to Sheffield. So clinical research is, well, research is essential in terms of trying to move the field forward, in terms of trying to identify and develop new treatments for patients. All the treatments that we give, imatinib, sunitinib, everything that we do is based on evidence. It's based on clinical studies that have been done so that we know that what we're offering is the best way to treat patients, what the upside to offering a particular drug, but also then what the downside is, what are the side effects, and we get all that information, that evidence from doing clinical trials. So initially I'm going to talk about an adjuvant study. When imatinib was first identified, the studies that were done initially with imatinib were in treating patients who had metastatic disease, who had advanced disease, and imatinib was shown to have, fantastic results, dramatic results. And so there was then the question that was raised, well, is it something we could use as an adjuvant therapy to try to stop or delay the time before the cancer comes back? And so there was a study that was done that was looking at giving 1 year of adjuvant therapy, and that was successful. And so they then went on to doing a study saying, well, if 1 year of adjuvant therapy is good, how about 3 years? And 3 years was shown to be better than 1. So the next question is, well, if 3 years are good, how about 5 years of imatinib? And so this is the study. At the moment it's called SSG12, which doesn't really trip off the tongue particularly well, but it's a study that is run by the Scandinavian Sarcoma Group, who I think actually ran the 3 versus 1 year study as well. And it's looking at giving 3 years versus 5 years of adjuvant imatinib for patients with operable GIST with a high risk of recurrence. And basically what it means is that all of the patients who go onto this study will have the standard 3 years of imatinib. If they've got a high risk of the GIST recurring, they will have 3 years. And normally at the end of 3 years, what we do is we say, well, you finished that treatment, and now we will stop that treatment and we will follow you up and we'll do regular scans. And this study is saying, well, should we carry on to 5 years? And so half of patients on this study will receive an additional 2 years of imatinib, and the other half won't. They will carry on being followed up. Actually they will be followed up for up to 10 years for us to then see, is there a difference between the group of patients who receive 5 years against those who receive it for 3 years. So you could think, well, 5 years has got to be better than 3. Why don't we just give 5? Why not 10? And you could suggest that, but there are downsides to imatinib. And one of the questions that we don't know is if you have imatinib for longer as an adjuvant, does that mean that you can have it for less time if the cancer recurs? So do you pick up mutations sooner if you end up having to go on to imatinib into the future? Imatinib is generally very well tolerated, but there are side effects, and there are potentially quite serious, rare side effects. So occasionally it can upset the lungs. It can cause what we call pneumonitis, which is inflammation in the lung. It can upset the heart, can cause heart failure. It can upset the kidneys. It can cause kidney failure. Now, these are very rare side effects, but if you stay on a drug for a long time, you're more likely to get these rare side effects. And so one of the important things from doing this sort of study will be not only to look at what's the good thing about staying on imatinib for 5 years, but also then what are the downside, what are the additional side effects that you might develop from that. And then that will help us to decide whether 5 years should become the new standard in the future, or do we stick with 3? This study's been taking a while for us to get set up. There's always a lot of red tape associated with trying to open a study. but we're hoping that we should be able to start offering this to patients in Sheffield within the next couple of months, which would be good. So I'm just going to talk then about a couple of other clinical trials which I am hoping that we are going to be able to offer to Sheffield patients in the future. We've been approached about these studies from drug companies, so they've asked us if we would be interested, and we've said yes, so we're waiting to hear back to see if we can try to take that forward. So one of these studies is something called the CRENO-GIST study. So there is, I've talked about these mutations that we find when we do the mutation analysis. And there is a particular mutation in the PDGFRA gene, something called the D842V mutation, which is inherently resistant to imatinib. And unfortunately, the mutation doesn't respond particularly well to sunitinib or regorafenib either. And this new drug, crenolanib, has been identified in early studies, in preclinical studies, so that's in lab studies, but also in an early, what we call a phase 1 clinical trial, as showing response, quite excitingly, in patients who have this otherwise resistant mutation. Now, this mutation is very rare. It's not a common mutation, but at the moment we have very little to offer these patients. We end up using the drugs that we have, but we know that they're not very good. So this is a study that will offer crenolanib. Within this study, so it's an international study, and it is a study which will be opening at the Marsden. So Robin Jones down there is looking to open, and we're hoping that we're going to open it up here as the sort of a northern centre within the UK. But it is rare enough that the study are expecting that each site that opens will only recruit 1 or 2 patients. So, you know, it really is not a common mutation. And the way that the study will work is that, again, it is a randomization. So some patients will get active treatment and some patients won't. And actually, this is a sort of study where we use what's called a placebo, so a dummy. So patients won't know and doctors won't know whether you're actually receiving the active treatment or not. That's to try to make the results of the study as robust as possible, so that we know that if there is a benefit, it truly is down to having the drug. And it just gives us much better quality evidence.
Is there a crossover option on that?
No, unfortunately there isn't. So I think there was quite a lot of debate about how this study should have been set up, and crossover was one of the things that was looked at, but from the point of view of the sponsors of the study, one of the key things that they have to try to demonstrate to try to get the drug licensed is benefit and overall survival, and they felt that that would be difficult to show with crossover. So unfortunately not. Sometimes we do what we call this randomization, where it's 1-to-1, so half of patients get the drug and half don't. This is a 2-to-1, so we're aware that there are going to be a group of patients within this who are going to get a dummy tablet that we know is not going to really do it, though it won't do anything. But rather than doing that as a 1-to-1, it's a 2-to-1, so it will be a third rather than a half of patients. Of course, the thing to bear in mind is that the standard is, we don't have a good standard, so they're not necessarily missing out in that there isn't an effective alternative. But what I think what the sponsors are very keen to do is to do a study that is as quick and as easy to show that there is a benefit from this drug, so that actually it can then be offered to, you know, a wider group of patients, and they felt that this is the quickest way to achieve in that. Another study which we are hoping will come to Sheffield is a study of a drug that is currently called DCC-2618. So at the moment we know that imatinib is a very effective first-line treatment, when or if that stops working, we then switch to a drug called sunitinib and then to regorafenib. But after regorafenib, we don't have anywhere to go. Actually, drug companies are starting to show quite a lot of interest in trying to identify alternative agents. So one of the studies which is up and running at the Marsden is something called Blue 285, which is another drug. We have referred patients down to the Marsden to go into that study. So this is an alternative drug called DCC-2618. This is a very early study. So the aim of this study is not primarily about trying to see if the drug works. It is primarily about trying to see what the safety is, what are the side effects, and what is the dose that we should give. So it's a drug that's not been tested in patients, so it's a really very early study. And we have to do these initial studies, what are called phase 1 studies, for us to see if a drug is safe, see what the side effect profile is like, for us to then be able to go on to do subsequent studies to see, actually answer the question, does it work, does it do anything? So this is an early study, and because it's an early study, they're quite intensive for patients, because we have to do lots of blood tests to see if we can measure the drug in the bloodstream, and there's often quite a lot of scans that are involved. So they can be quite intensive, but you know, certainly beyond imatinib or beyond sunitinib and regorafenib, where options for patients are reducing, then this could be something that would be, you know, it's another option that we can offer. So again, we've expressed an interest saying that we'd like to be able to offer this in Sheffield, so we're waiting to hear back from the drug company whether we can take that forward. And then finally, a study that I want to mention that we are looking to do. So when we give treatments to patients, then obviously one of the key things that we are doing is wanting to do a study so that patients live longer. And we want to give treatment so that we can see that we are helping to control or to shrink the tumour down. And scans can often give us a lot of information, CT scans and things like that. But scans only give you part of a picture. And this study is actually looking to try to develop a tool, a questionnaire basically, that could be used in clinic to ask about key questions to patients as a way of measuring, are we actually helping with giving this treatment? Okay, and this is not just for GIST. This is a sarcoma-wide questionnaire that they are looking to develop, and this is a study that is being run from UCLH, but they are looking to open it out across the UK for all patients with sarcoma, and it basically involves focus groups and interviews to try to pick up common themes to develop questionnaires. They're trying to recruit patients through through the clinic, through the NHS, but also through support groups and charities as well. So that's me. Thank you very much for listening, and I will hand you over to Christine.